listening via the internet to this seminar. So today we have our first speaker, who is Professor Rama Baru, who is also the chair of the Center of Social Medicine and Community Health at the Jawaharlal Nehru University in New Delhi, India. Her research focuses on health policy, international health, and in particular privatization of health services and inequalities in health. She's the author and editor of several articles and books, including one on private healthcare in India and on social health services in India. She was awarded the prestigious Balsan Fellowship by the University College London, and also the Indo-Shastri Canadian Fellowship. She's a regional editor for the South Asia for Global Social Policy, which is a publication of SAGE, and she's a member of research committees for the Government of India, for the World Health Organization, the Indian Council for Medical Research, and the Ministry of Health and Family. So I'd like to welcome our first speaker, Professor Baru. Thank you.
Thank you very much, Mr. Homan. Sanjay and Thompson, for inviting me to share some of my work and my concern for the socio-economic inequalities in access to maternal health care. I have chosen this specific topic to, one, unpackage the reasons for the slow decline of maternal mortality, and also to really look at maternal health care because it's a privilege within the general health services in India. But my basic thesis is to really examine how commercialization of health services is partly responsible for the persistence of inequities. This paper provides a brief overview, as this slide shows, of socio-economic inequalities in access to maternal health services. It tries to explain why these inequalities persist, and it argues that commercialization is a determinant of accentuating inequities and contributing to poverty. This piece of work really draws and connects to a body of research in the last 30 years globally and in India that has examined commercialization and that has really argued that commercialization has fundamentally transformed health systems and moved them from the normative values that they were supposed to embody. It also connects to the Commission of Social Determinants in Health, where the Knowledge Network on Health Systems and the papers that contributed to the Knowledge Network on Health Systems tried to argue this. And this strand of research and empirical evidence has been rather peripheral to understanding and explaining how we deal with public systems, especially in middle and low income countries. This is just a very quick overview. We are really looking at the paradox of India's development, where you have very high sustained economic growth, and I've just sort of provided the figures there. From 1950 to 80 it was 3.5, it moves on to 5.5, and for the last 10 years we are very proud, and this is something that is constantly highlighted, which is that we have a sustained high economic growth. Yes, we have high economic growth, but if you look at health outcomes, MMR, IMR, under 5 mortalities, they are unacceptably high, and a lot of the literature, both from the WHO, MDGs, etc., have been constantly commenting on the slow decline and worry about whether you would reach the goals that it has been set. Now, the important part that I want to bring into this presentation is that India really offers a complex picture of multiple inequalities. You're talking about regional, sub-regional, social and economic dimensions. And I really identify class, caste, gender and religion as very important axes of inequalities. And when you examine the Indian data, you do see these inequalities reflected in health outcomes and access to health services. We have macro data sets which allow us to establish these relationships. The DHS, which is called the National Family Health Service, clearly show you these relationships, and in fact the averages mask these inequalities, and it is this that I am trying to highlight in this presentation. But what is important also to understand is the limitation of these macro data sets. While they give us some amount of variation in terms of socio-economic inequalities, it does not allow us to really examine intersectionality. Just to give you a very, very quick example, you can get data on religion and health outcomes. You can get data on what is happening to the scheduled castes and scheduled tribes, who are the most marginalized historically and otherwise. But you will not be able to get intersectionality in terms of what happens to a woman belonging to the scheduled caste living in Tamil Nadu versus somebody a similar socio-economic background living in UP. So the regional and the historical specificities are not captured by this data set. There are a few studies which have been done at the state levels, and I've given some references, and if you're interested you can pursue them, that have demonstrated the complexity when you bring the intersectionality into play. Now, interestingly, there are also a few micro studies more recently that have examined the relationship between inequalities, commercialization and access. So in a sense, the inverse care law by Hart holds that those who need the most are getting the least, and what they are getting is also not of very good quality, both in the public and the private sectors. Now I'm going to skip through some of these slides very, very quickly, but just to show you the drama of inequalities, what I've done is I've taken under 5 mortality 2006 from the National Family Health Survey data, and if you can quickly look at the regional, which is I've taken urban Kerala and rural UP, the extremes, then I'm looking at education, mothers with no education. The black bar is the all India average. This is the point I'm trying to make. When you disaggregate the all India average, you're getting this kind of a picture. Then you're looking at the scheduled tribes and the non-ST, SC and OBC, which is the scheduled caste, and I'm not going into the details of what is caste, but I could take this up in the discussion if you like. And then you're also looking at the highest quintile versus the lowest quintile. So this graph really shows you the drama of inequalities. While the average is 74, you have a range of 14 to 117 in terms of regional disparities, and of course across selected socio-economic indicators. Now the social gap, if you look at the percentage of the OBC, that is the SC, the ST in relation to others, you again find that it is very high for the scheduled tribes. These have become in fact marginalized even more if you look at the trend from the early 1990s to 2005 and 6. Similarly, I tried to do the same for immunization. Again, a picture of drama in a sense of what happens when you disaggregate this data across socio-economic inequalities, and you clearly see that there is tremendous variation and extremely misleading. Now what I tried to do, the picture for antenatal care is very similar. I have not put up another slide for that, but essentially that there is this kind of a disparity that continues to exist. And secondly, the quality of antenatal care also varies extremely across states and across socio-economic groups. I decided to look at delivery services and again try to show you the kind of drama of inequalities that it presents. So you have, first of all, very low level of institutional deliveries in India, which is at 39%. But if you look at urban Kerala, they almost have 100% institutional deliveries, but rural UP falls somewhere at 16%. And then when you look at it across social groups, the STs have the lowest, and then you look at the scheduled caste and the other backward class, and then you find that between the others and the more marginalized, again there is tremendous amount of gap.
of the institutional deliveries, I tried to look at across wealth index, what is the pattern of deliveries in a government health facility when compared to total deliveries. And here again, there is clearly a gradient, and this is something I'm not going to get into now, but the constant refrain in a lot of the literature is the rich-poor gap in Indian health services, access to Indian health services. I really argue that we need to move away from this dichotomized understanding of the rich-poor gap to really look at the evolution of a certain gradient in access. And this particular graph shows you this. And whatever is remaining, majority of it is in the private sector, and it is not in the NGO sector. So the data clearly is showing you that the percentage of deliveries in institutions is low, but the percentage of deliveries in government institutions is very low as well. Okay, now I just want to very quickly, in the literature you have commonly cited reasons. You always have this explanations in terms of supply side factors like weak public provisioning, poor quality of services, all very well known. And then the demand side, which talks about lack of knowledge, cultural beliefs, poverty, lack of purchasing power. And so there is a whole lot of literature that tries to argue in this fashion. What I would really like to do is sort of move away from that, because I feel that it is inadequate in its explanations. And here I really look at health service determinants and socio-economic determinants and how they intersect, and they in a sense are responsible for the persistence of inequities. And here I'm really foregrounding commercialization of health services as a key factor, if not a determinant, perpetuating inequities in access. A lot of the literature has tried to say that, for-profit sector has been responsible for rising inequities. And there's a lot of literature from Africa especially and Latin America that has argued this. But I'm really moving this beyond that definition. I'm not just looking at for-profit, but I'm looking at the term commercialization. And here I draw upon partly the work done by people like Lucy Gilson and then commercialization to include processes like marketization, commoditization, privatization, and liberalization, because the argument is that market relationships are not just outside public systems anymore. Market relationships have been, in a sense, historically been accommodated within public systems, but these have changed over time. And for low and middle income countries, the 1990s, really post-1980s, has been a period of introducing a range of market relationships into public systems on the notion that it promotes efficiency and effectiveness. So therefore, we want to really analyze or unbundle the concept of commercialization. We have to see it in this rather full spectrum. Now, when you look at the literature, there is also the attitude to public and private sectors is sharply divided. There is a body of literature in academia, largely from the area of health economics, that talk about public versus private good or merit goods. It tries to look at the public as something that is supposed to embody all the values of normative concerns and values of equity, while private sector is supposed to be much more efficient. Now, there is also another body of literature which says that this kind of a dichotomized view takes away from our understanding of commercialization and what it does in terms of inequities in access. So like I said earlier, that I'm really trying to unbundle this complexity of commercialization of health services, and I say that it needs to be, you need to take cognizance of the fact that you're not just addressing the for-profit sector here, but you're also looking at how the public sector has got commercialized over time, and therefore the change in the behavior of institutions themselves. Okay, I'm just going to look at how does commercialization embody inequality, but before that I'm going to really go very quickly through the history of commercialization of Indian public health services. And this is important because a lot of the writings have sort of begun with the 1990s as a benchmark for commercialization, and saying the World Bank and the IMF came into India, and then the conditions of formal and informal payments in public services during the post-independence period. we think user fees is something which is just a post-structural adjustment phenomena, which is not quite the case. If you look at it historically, you had payment systems, very minor, in public services, especially at tertiary care, but you also had the idea and the accommodation of informal payments. And these informal payments were often described as honorariums for health workers. They were sometimes, and to the other extreme, were bribes to get good quality care. So this is not something that is a phenomenon of recent times, that had historical roots. Now what is very important and what fundamentally transforms this process of commercialization is the rise of for-profit health services since 1970s, and you really have a very large differentiated for-profit sector, and you have both the formal and informal providers coexisting in this large differentiated for-profit sector. And you also find that the institutional arrangements, in a sense, replicate the social hierarchy. That is, you have a range of institutions of varying sizes that match the capacity, the paying capacity of patients across the social hierarchy, and clearly differences in qualifications of providers, scale of operation, and therefore quality of care. Now, one big story in the Indian health services has been the lack of regulation. I'm not going to really discuss that here, but regulation is seen as a technical issue. It is seen something that the state must be doing to control the for-profit sector. However, the evidence that we have from some of the small-scale studies is that it's not purely a technical exercise, that the levels from the informal to the formal and the corporate sector have political links at the local, national, and global levels. So the issue of regulation is far more complex than and not just a technical issue. The other very important aspect when we look at commercialization in India is the nature of interrelationships between the public sector doctors, paramedical personnel with private institutions. And here I mean public doctors are allowed private practice. Initially it was individual private practice, but these relationships evolved into fairly complex relationships where public sector doctors were in fact promoting nursing homes and hospitals, or they were acting as consultants in private nursing homes and hospitals. So the boundaries between public and private and the diversion of patients from public to private became fairly common even in the 1970s and 80s. And this, in a sense, is reflected in the way in which people use and perceive public institutions as well as the reasons for going to private institutions for care. Now, there is another body of literature which is arguing and showing through evidence how health sector reforms has accelerated commercialization, both in the public and private sector. The NSSO, that the National Sample Survey data for 3 rounds, is showing you that the cost of medical care in both the public and private sector has increased, but there is a differential between the public and private, clearly the private being much higher than the public. But it's important to note that even public sector is not provided free of cost, and that there is expenditure involved and fairly high amount of expenditure. In 2005, around 2005, there has been a lot of work done on out-of-pocket expenditures in the Indian health sector. It's very well known. We have one of the highest out-of-pocket expenditures. And this body of work is also looking at the adverse consequences of out-of-pocket expenditure for access, for cost, and for quality of care. And we're looking at it for both public and private sectors. So this is an important body of work because they are also showing you how high expenditure on health services is pushing households into poverty, and it's also a defining aspect of being poor. So both these things are happening, and those who are poorest are being denied care. And in fact, the National Sample Survey data shows you when people who didn't go for treatment were asked why they didn't go for treatment, they said the cost of care was the most important reason. They couldn't afford it. Now, I've been looking at there's little less work done on maternal health services. A large amount of that work is on general health services. But more recent work is showing you that there is high out-of-pocket expenditure and rising burden on households, leading to differential levels of impoverishment of households. And I come back to the social gradient. So while the very poor suffer the most, the not so poor and the large undifferentiated middle income quintiles in India are also bearing significant amount of burden. a story that has not really been, I think, told or argued adequately. And secondly, it also shows you, and this is very recent work with using the NFHS data, which is showing you that there's a significant poor, non-poor gap in access to maternal health services. And very often the reasons for this are attributed to the growth of for-profit services and a deficient public sector, which I had earlier flagged. Now, what are the consequences of commercialization for maternal health care? One very interesting area of work which is coming up is looking at informal payments for antenatal, delivery and postnatal services to the public sector. And for the poorest, it forms a significant percentage of expenditure on maternal health care services. And very often, and there is a lot work even in the Commission's report on the behavior of institutions. And here you find that informal charging in the public sector is often linked to abuse, exclusion and impoverishment. So this quality of care which we get data on needs to be unpackaged, and we need to understand it in relation to commercialization. And you also have evidence from the NFHS3 and other studies that a shortage of supplies in public institution, in a sense, force women. So in fact, the out-of-pocket expenditure data shows you the largest percentage of expenditure is going on purchase of medicines. The other very interesting, important issue that comes up in the health sector reform debate is the introduction of public-private partnerships, the contracting out of diagnostic facilities in public institutions, and also a referral from public to private institutions. And I don't want to get into the details, but I have studied this phenomena where you have a government doctor owning a diagnostic center or having links with the diagnostic center where he gets a commission for the patients he refers. So this back and forth linkage which I talk about between public and private sector and between the formal and the informal sectors. So in a sense there's a vertical integration within the for-profit sector between right from the corporates to the informal. And I have an anecdotal evidence of the corporate group Apollo, and this has been actually evidenced and studied, where they have links with informal providers for referring cases directly to them. And there is a system of commissions that are very clearly built. Now, therefore, paying for care has been deeply entrenched in both the public and private sector. And I argue that this actually has resulted in the blurring of boundaries of the roles of the public and private sectors. And the other point I want to make, which is about how institutions behave, rising commercialization has altered the behavior of public institutions and personnel. The normative values of public institutions has been gradually eroded. And this is a piece of work that I did with retired government doctors from a premier public institution, where we could clearly see, in a sense, the constant comparison that government doctors make with their private counterparts. And in a sense, there is a devaluing of their own self in these institutions, as well as the morale of public institutions. And therefore, they feel that, they're doing a favor to people who are provided quote-unquote free cost. And why don't they just go pay for care? So, there is this, the normative values of public institutions has certainly undergone an erosion. And I do see commercialization as a very important determinant for that. Okay, in summing up, what I really want to argue is that there is a complex interaction between socio-economic inequalities and health services, and commercialization is an important driver of inequities in access. Now, there is a body of literature which argues that, yes, people talk about the need to regulate the for-profit sector and how we must strengthen public systems, as if these are two separate issues. What I'd really like to argue is that you need health services planning which takes on board what is the role of the private sector, an extremely differentiated private sector at that. And regulation cannot be just of clinical establishments, but how do you bring in a frame for regulation that takes care of this diversity of providers? And how do you bring in a framework for regulation that also addresses commercialization of public services? So it is a fairly complex area, but we need to really look at both health services planning and regulation in tandem with one another and not separate and treat them as independent entities, because in reality they're not. I also feel it's very important, especially in recent times with the National Rural Health Mission in India, with a great push for cash transfer, conditional cash transfer programs, etc. We need to understand and recognize what is the limit of health services in addressing inequalities in access, by which I mean that yes, health services can play a very important role in mitigating inequalities in access. But can they actually eliminate inequalities? And I think that's where we need to be very careful to understand that there are structural inequalities that cannot be addressed by just the health services. Because when you look at some of the data on the expenditure incurred by poor households, the direct expenditure is one part of the story. But the larger proportion is the indirect expenditure, which means you're looking at loss of wages, loss of employment, and other issues that in a sense prevent people or drive people into having to borrow money to pay for care. So the last point I'm really making is going back in a sense to the alma mater and saying that there is need for greater intersectoral coordination. That is, everything cannot be, the problem of inequalities in access cannot become the problem only of the health services, but the health services and the poverty reduction strategies really need to speak to each other much more than they are now. Because what we find in the Indian context is we have series of vertical programming for poverty reduction. We also have vertical programming for reducing inequities in access to health services, but you do not see these various vertical programs talking to each other in any significant way. I'll just end with that, and I just have 2 slides of references for those of you who may be interested in pursuing it. Thank you.
Okay, so before we open up for questions, we have the second speaker, and so this is the speaker from WHO, and we are very pleased to have Dr. Ritu Sadana, who is currently in the Department of Health Systems and Finance.
Thanks very much. And it's quite an honor to be asked to speak after Professor Baru. So I hope to be able to provide just one perspective. And part of the reason only one perspective is that there are many of us here who are working on these issues. So I just will try to discuss a little bit about the context in terms of putting this into a WHO policy perspective. Some work that WHO has supported on monitoring and analysis, and picking up from the challenge and the questions asked by Professor Baru, can we connect this to other determinants? And please let me know if I'm going too fast or too slow. This is not my slide. I'll try to be as intellectually honest as possible, but I've adapted it slightly, which basically shows a kind of a report cover history, because we often have lots of reports and we have meetings and we launch partnerships. So even if these seem rather ad hoc, in fact, they tend to have some logic in terms of the policies that are important at that particular time. Because again, WHO is member states plus the Secretariat. So a lot of our stuff, which most staff know, go on at the World Health Assembly and with our executive bodies. But what we do as the Secretariat across some 9,000 staff in 150 offices around the world, is in sync and extending that work. But as you know, from 1948 with the Constitution, and then the work more recently in relation to alma ata, as just described, was really looking at a broad, comprehensive view of what does primary health care mean, and the sorts of services that one would imagine should fall under maternal health. But if you look then during the 1980s, this was not necessarily always sort of kept clear. There was a major effort in '87, the Safe Motherhood effort, which tried to say clearly that that there are many reasons that we need to reduce maternal mortality, and we have to have a call for action. It was done with the World Bank in collaboration with WHO and UNFPA, and they had very specific areas that they wanted this action to occur, even very specific things like looking at severe bleeding, infection leading to sepsis, the effects of unsafe abortion, eclampsia, and obstructed labor. And Carla Abuzar, who's a staff member at WHO, she's here still right now here, she wrote a very nice historical review analysis of what happened to the Safe Motherhood program. And one of the things she mentioned was a quote by James Grant, who was the head of UNICEF, 2 years after the Safe Motherhood program was launched, saying, actually, the emphasis on goals for maternal mortality is largely a byproduct of child survival efforts. So it gives you a sense, a very abbreviated or truncated sense of the different perspectives, even in the global arena, on the importance of really focusing on maternal health. To sort of skip forward, in the 90s, we had a lot of work on burden of disease and coming up with selective packages so that we could address very specific interventions. And in the years of 2000, the last decade, we had lots of partnerships launched, and in this particular area, WHO launched one in collaboration with something like, I think there's more than 300 groups involved in the Partnership for Maternal, Newborn, and Child Health. And they are specifically addressing MDGs 4 and 5. And in fact, I think they had their declaration, it's called the Delhi Declaration. So it seemed to be another effort to try to come now, not just with UN agencies, but also a much broader range of civil society and other groups who want to work on not just maternal health, but on a range of issues. And I think their logo is the one in purple, just under 2005. And more recently, WHO had the Commission on Social Determinants of Health, which Professor Baru mentioned, and I'll just come back to that. And most recently, last year's flagship World Health Report publication was on universal coverage, but really how to finance it in a sustainable way. And I think that's very relevant for the issues that Professor Baru has mentioned. Now, in terms of MDGs, we have several people in WHO who are working with many others on actually monitoring the indicators to measure progress. And I think probably you know these, but certainly on MDG 5A, it's the maternal mortality ratio and the proportion of births attended by skilled health personnel. And I'll use 5.2 there as an example coming up. But also for 5.B, the key is to have universal access to a range of reproductive health services. And what I try to do is just to give some flavor of what do we mean by universal access, and are we actually measuring what we want to measure. What's very interesting is that although these are measured in national averages, as has just been discussed, that really masks what's the variation and perhaps what are the strategies then that we could actually try to improve progress toward these goals within each country. And our Director General, Margaret Chan, since about 2007, has been saying repeatedly that progress in reaching the MDGs will not be measured by national averages. In fact, she says it should be measured by improvements in life for society's most miserable and least visible communities. And I think this was repeated in a series of policy discourses in New York, as well as in many other places. And I think what this tries to state at a policy level, a very high-level policy level, is that we should try to shift the discourse from a technical target to one that really talks about social justice at the local community level or the state level or within a country. The problem we have is that data systems are not really set up in most countries to do this systematically. And I think this is some of the challenges that Professor Baru mentioned in India, a very large country with actually sometimes some very good data sets, but a very large country where you would want to do very detailed analyses that consider, you mentioned intersectionality, or in maybe data statistical terms, multivariate analyses, where you really have sufficient sample sizes to do that. So now moving a little quicker, in order to develop, though, this global, regional, or even national agenda, if you consider MDG 5 just as an example, you sort of want to say, well, what are the implications for the health sector? And in a sense, that's what most of WHO's work is focused on. And, you know, we have several departments here in headquarters who are working with the regional offices and country offices in what are our core functions, you know, whether it's leadership, research, norms and standards, technical support, as well as monitoring. And this is very important. But I think to address this sort of final question that you asked, you know, if we only focused in that box, are we going to actually reduce inequities, or that are, you know, that we're measuring by these sort of national, or if you have data, subnational targets? And I'll try to give a little bit of evidence saying unlikely, because much of what's contributing to the inequities, not just the national averages, but the inequities are actually outside of the health sector. It doesn't mean that government doesn't have no role, but that government and many other actors actually have a very important role. And how to figure out what to do is the challenge, is that, you know, it's very context specific, but it's the challenge we're facing. I'll try to cite a couple of pieces of work done by WHO staff, or led by WHO staff. One is a paper that Phillida Travis, who's a staff member here, put together, where, with many others, on what are the constraints, at least on that health system side, to move towards achieving MDGs. So this is generic. It's not for any, it's for the health MDGs. And I just point out two things. One is the financial inaccessibility, the inability to pay, and one response is to pool the funds so that those who are sick don't have to, are not the only ones who are paying for it. So it's a social protection, and come back to that. And just another one is on the lack of intersectoral action and partnerships. And I think this gets at the heart of trying to improve inequities, because so much of why we see the variations within countries are due to this lack of working together. In terms of monitoring analysis, there's some pieces of work which I think is nice to highlight in terms of what WHO has been doing, not just only in headquarters, but also in regional offices and with country offices. And I think that's very important, because we're speaking here, but we have a lot of activity going on in different parts of WHO to support national efforts as well. And I think it's important on the monitoring and analysis side, because it's one way to sort of see, are you actually achieving the idea of greater social justice, trying to unpack what's happening at the subnational level. So another piece of work that was done a while ago, 1978, and in fact published within the Bulletin at that time, the Bulletin of the World Health Organization, is a paper by Tanahashi, who I think was very forward-looking. This was just around the time of Alma-Ata, to try to describe, well, what do we really want to measure? And he described different aspects of access, and saying, well, what we really want to measure is how effectiveness coverage. That's how it was termed. And that would mean effective services are provided to all in need. In fact, that's what we're calling universal coverage now. It's not saying that the service's impact is effective, but that it gets to the person who needs it. And that it's not simply whether it's available, that's somehow a supply, or if it's just geographically or financially accessible, but that it's also acceptable in terms of the individual or the family or the social, cultural aspects, and that there actually is an appropriate contact where the services are really delivered and there's follow-up. And then you could say that the services are actually effective if they're given in a quality format. And what's interesting is that it sort of looks at the whole process, and back in 1978 argued, well, in fact, that's what we should be measuring. But what we actually measure pretty much always is availability or accessibility coverage. And that's what the data systems mostly allow us to do. There's small studies, not just, and that's not just in low or middle income countries, but also in high income countries. Sometimes in high income countries it's even more complicated, depending on the country, where there's no coordination of care, to try to get that, to try to get beyond availability or access information. But I just put the text up here to say that really, if we want to know the proportion of the population in need of an intervention who have received an effective intervention, that's effectiveness coverage. And sort of the key to measurement then is what's actually an effective intervention, or whatever the intervention is. And I think colleagues who are really working in maternal health can tell us that based on their evidence-based reviews with the scientific community. Now, the measurement of an effective coverage, it's an intermediate goal because we're interested in improving health outcomes. And there is a clear link to health system performance, because here we're talking about an intervention that's delivered through a health system. But there could be other interventions delivered through education, through the media, etc., that aren't connected to health systems as well. And that's just to make that clear. Now, I'll go kind of quickly now because these are just some figures and slides. If you look at income per capita, income per person on the x-axis, and life expectancy in years, and I think this is like for most recent data in a nice book that Wilkinson and Pickett put together called The Spirit Level. And you just put the countries' names. I've just put India in a red circle because you can't read all the countries there. You see that there's huge variations. I mean, this is nothing new to see a slide like this. There's huge variations with a lot of countries who, you know, are outliers or who you wouldn't expect, but you see huge variations. And that's at the national level. But what we're interested in is, well, what about the variations within countries, and how can we look at that systematically? And in the 2005 World Health Report, there was a very nice set of slides, a set of data and the way it was presented. And it looked at just one aspect, looking at household wealth quintiles, which Professor Baru mentioned as well, on the x-axis. So these will be the averages for 20% of households based on household wealth or household assets often, and then their access to a particular service. And you can see a pattern if only the poorest households don't have access. Number 3, that's considered marginal exclusion, meaning most of the people, the better off, have services, whereas number 1 is called mass deprivation. It's just a heuristic, but it's helpful to say, well, it's only the richest who have access to a service. And again, we're often only measuring this by accessibility. But actually, when you look at data, whether it's from demographic and health survey data or from others, you see these patterns, these social gradients. This time it's by assets, but you can also see it by education. You can see it, it's not ordinal, but you can see it by different types of employment categories as well. And you see that, for example, Bangladesh in 1993 had this mass deprivation when it came to births actually delivered in facilities. So it's not skilled birth attendants, but actually facility deliveries. And you see that in Dominican Republic at the very top, you can't even call that mass exclusion. But, I'm sorry, you can't really call that marginal exclusion because they're so high up. But you could say that for perhaps Colombia in 1995, the overall pattern, it's the poorest group that can be brought up. And you would use a different set of interventions to change those. You can see improvements. There's two sets of data for Côte d'Ivoire in the middle there, and between 1994 and I think it's 1998, there was an overall improvement across especially the middle social groups, which is interesting because often I'm going to show you a couple of slides where we compare the poorest with the least poor, or the richest. And if we had done that for the Dominican Republic, for Côte d'Ivoire, using this data, you wouldn't have seen much of a change because the interesting part is actually happening in the middle quintiles, which we often actually don't compare when we're providing information sort of succinctly. So what is WHO doing in trying to actually unpack this information? We have a whole department on health statistics, and they have an advisory group, and several years ago they actually proposed that in our core monitoring of health statistics, that we should have a series of types of core data that's actually broken down by within-country differentials, whether it's by place of residence, by education, or by wealth. And the three that are highlighted there, actually the child mortality, the institutional delivery or skilled birth attendance, and measles immunization are the three that currently are being monitored. So that information for about 100 countries already now is published routinely by WHO based on the household surveys in primarily low and middle income countries. Okay, so what are some other aspects that different offices are doing? For example, the African region just completed a study of 30 countries trying to look at the inequalities and inequities. And what's pretty interesting, and here I'm just showing a couple of slides. Here's one on skilled birth attendants. And what this slide has is on the x-axis is the over roughly a 5-year period, it's the change in the national average. So that's the national average. You know, is it getting, are more women having skilled birth attendants, the prevalence? And over time, is there a plus? So you want to be in the green box moving right, because the green box is where you want to be. And on the y-axis is there a change between the ratio of the lowest quintile to the highest quintile? And are you moving in the right direction so that you're decreasing the inequities? And here, you want to be in the green box as well. So you have a bunch of countries which are in the green box. That means that they have an increase in prevalence and they have a decrease in inequity. So we're sort of combining two bits of information. And you have countries which are in the red box where you don't want to be. And here you have a decrease in the average, and you have an increase in inequity. And I've just put an arrow to Kenya, because Safe Motherhood was launched in Kenya, just to show that just because on one indicator you may be not doing very well at all, it doesn't mean that you have the whole story about maternal health and inequities. So you can look at some other indicators from Kenya, and although they were
in the red box for delivery by skilled attendants, they're actually in the green box for the use of modern contraception for women with express need. So that's something positive. I mean, that's a positive. So it's describing and communicating are things getting better or worse in relation to inequities is complex. And it takes time, like I'm taking time right now. So it takes time to actually to show that. So here's just the picture of Kenya in relation to other countries that had data in Africa over time, where they're actually in the green box. And the report's very interesting because it looks at national averages, it looks at the least poor and the poorest, and it tries to show really what is the variation within countries. So just quickly, here's one on are women who are pregnant using anti-malarial drugs. And it's actually very few countries where there's any use, and a few countries that are doing pretty well, if you look at Malawi, but huge variation. If you can also see, are they counseled for HIV during antenatal care? For the few countries that have data, very few countries have data, first of all, and the variation within countries is quite a lot. Just turning to Southeast Asian countries, CIRO has also, our Southeast Asian regional office has also done a similar analysis where they've reanalyzed existing data with country partners. And this one is looking at prevalence of maternal underweight. I just picked different indicators that are kind of more or less within the MDG5, even if they're not specific to MDG5 indicators. But showing that actually the first two points are Bangladesh 97, Bangladesh 2004, then it's Nepal 96, where there's very little there's almost no variation, but pretty low, so it's okay, better. Well, not okay, but lower. And then two data points for Nepal, and then India from the 98-99 survey showing a lot of variation, unsurprisingly, and Sri Lanka. If you look at skilled birth attendance, some trends for some countries, Bangladesh, pretty flat. India, that was before the data from the more recent surveys, but a wide variation from less than 20 with the lowest quintile to over 80% for the richest. Some of the information that Professor Baru gave us. But what I'm trying to show is that in our regional office, they're trying to actually put this in context in the region, which supports regional policy discussions within their regional committees and bodies as well, and an exchange of information among people who are, and countries who are more similar, but not exactly the same. And why they're not the same, is that if you look at Sri Lanka and Thailand, almost all births are attended by skilled birth attendants, and there's almost no variation. And there's a very clear set of policies and interventions that are delivered both within the health sector and outside of the health sector that enable that to happen. So it's possible. And that's what I think is quite important to show, not only country data, but also data from countries that are considered similar, or have some similar constraints, but have maybe very different policies. I added this one in just to show that within Indian states, if you look at the percentage of the population in the lowest wealth quintile, this is more recent data, even that varies dramatically. So interpreting data in India is very complex. Although we use sometimes that one national average, even when you look at the lowest, the bottom 20%, it's very different across the country. I think I'll skip these because we went those. And just to talk a little bit about universal coverage, we actually have a policy, a World Health Assembly resolution in 2005 that defined what universal coverage is. So sort of a fast forward from Tanahashi to what the member states have agreed on. And it basically says that all people should have access to needed health services,
prevention, promotion, treatment and rehabilitation without the risk of financial hardship associated with accessing services. And the recent World Health Report, I think, in my opinion, asks three very pertinent questions. This is a report that David Evans was the editor on. Who is covered? Which services are covered? And what proportion of the costs are covered? And I think previously we were focusing only on who is covered and maybe the types of services. But I think exactly speaking to the concerns that Professor Baru has mentioned, this third question is considered equally important. And then just quickly a couple of, one example of some interesting analyses that are being done on the World Health Survey that took place back in 2002. And why I think it's important to consider that is that although DHS is interesting and has probably provides us most of the data we want to know about the disaggregated at the subnational level, it only occurs in low-income countries and a few middle-income countries. And all of the high-income countries are left out. And what's important is that at one point we had a survey program, short-lived, but it covered high-income, middle-income, and low-income countries, and it tried to ask questions that weren't just related to concerns of high-burden countries like maternal issues. Very important, but there are other things as well, like non-communicable diseases, etc. And what's interesting is in this this particular analysis done by a former WHO staff member, Emmanuelle Gankadou, and a couple of her colleagues, that was published in PLOS Medicine in 2008, it looks at 57 countries from the World Health Survey. And it basically shows on the x-axis the extent of coverage. And red is, in this case, cervical cancer screening. It's women who've never had a pelvic exam. Blue is crude coverage. The way they define that is that eligible women who reported that they had a pelvic exam. And effective coverage, in the way they defined it, given the survey they had, was it's the proportion of eligible women who had a pelvic exam and had a pap smear in the past 3 years. Okay, it doesn't go into details whether the pap smear was done correctly, et cetera, but at least tries to move up on that chain that Tanahashi had. And a bunch of countries are noted here. I think it's more interesting to see that the countries are ordered by the results, and I've just highlighted where India is. So the percentage of women who've had a pap smear is less than 10%. In fact, it's around 5%. So it's pretty small if you think of the eligible women, the number of eligible women in India. And they also looked at it across all of the countries, and they look at 10 deciles of wealth. So this is global wealth deciles, and it's unsurprising that effective coverage is also globally the smallest among the poorest, and it's a very clear gradient going up. Skip that. One of the ways we've tried to quantify what happens when you have to pay a lot is that you have a large amount of catastrophic expenditures, and worldwide that's about 150 million people per year who have these catastrophic expenditures, more than 40% of their assets. And about 100 million people are actually driven below the poverty line. That's in gray. And it's quite significant within the Southeast Asian region. And what I think is interesting in Professor Baru's presentation is that she provided us the information that India has been growing rapidly. But what's interesting, or maybe not so interesting, is that the total health expenditure as a percentage of GDP in 2007 was 4.1%, which is actually slightly less than it was in 2000, when it was 4.4. the pie is bigger, but they've also decided to reduce the slice. And is that due to or despite rapid growth? I'm not sure, but it's, I think, quite telling when the government expenditures, total meaning government and private, have actually gone down. I think India is an extreme example with the direct payments. It's basically hovering around 90%, which is an extreme example. The World Health Report suggests that you should not be more than 15 to 20% of direct payments. India also has a very small percentage of private prepaid plans, just about 2%. And to give you an example, a contrast, Thailand is about 20%. But the government per capita expenditures are still very low, only $11 US out of the total per capita expenditures of 40, which is low to begin with, but quite low. And just to end on connecting to other determinants, clearly we need to address the structural or the causes of the causes. And when the Commission on Social Determinants of Health was set up, they considered that there's sort of three questions that they should try to be able to answer with sort of a progression. And where do the health differences among social groups originate? If we look at the cause of the cause, what are the pathways that make us sort of see these very stark differences? And then, of course, what should we do about it? And they put together a model, very simple, which says that there are social, economic, and political sort of macro context, but it could be very specific policies, legislations, that generate social stratification, which is then the social position individuals have, and that social position influences the vulnerabilities you are exposed to, the consequences when you're ill, and also the lifestyles or behaviors that you adopt. And that the healthcare system in the sort of black box there is in itself a social determinant of health. And together, these influence and determine both the averages, but in particular, the distribution of health found within a particular country. And the last analysis I want to show before ending is that in the Southeast Asian region, specifically addressing your question, can health systems completely mitigate health inequities? The analysis based on national survey data found was that probably no. There was a decomposition analysis using the same Commission's framework, boxes, where socio-economic political context is the dark green, socio-economic position, the social position is the light green, those intermediary vulnerabilities yellow, and then health system factors blue. So it's important that health systems do matter. They matter significantly. But overall, social position was by far the most important contributing factor to the variation in skilled birth attendance. So it's not the national average, but actually the what's causing the distribution, or what's associated with the distribution, given the data we had. And I think that this is very important. It gives us some insight, but it doesn't tell us what to do. And I think that's where, the challenges with all of these partnerships and the types of works that member states and a whole range of NGOs are doing is to focus on what can we do to address both the health system factors, but move up the chain and address the broader determinants as well. And actually, this really is my last slide, because there are sort of some insights into these broader determinants. And this is from Indian data from 2005-06, where it was just looking at whether or not spousal violence was associated with actually utilizing maternal health care. And the results were significant for whether you had at least one antenatal care visit, whether you were assisted by a health professional or whether you delivered in a health facility. Certainly more multivariate analysis would be important, but if a woman said she never experienced spousal violence, she was more likely to have access to services than not. So I think it does give some insight from even the data that's currently at hand. Thank you very much.
Okay, well, I'd like to thank both speakers for their presentation, and I'll now hand over to Dr. Sanjoy to facilitate the discussion on the presentation.
Thank you. Now, as you know, the question and answer session is also being broadcast live over the webinar system. So when you ask questions, could you please identify yourself for the record so our colleagues who are listening in, I understand we have quite a few today, know who's asking the question. Sometimes we actually get interested emails from people, I understand, when they're interested by your questions. So can I throw the floor open for questions or comments? Well, I'll start in that case while people mull over their questions. I mean, the final report of the social determinants of health, do you think it deals with the issues you've covered adequately? I know this is I mean, the analysis both of you present is based on very critical assessments of available data. In your opinion, does the final report of the social determinants of health engage adequately with the data you just presented to us? Both of you, please.
I would say that the Commission's report does not adequately address some of the critical questions that I've raised, and this is something we have in fact written about in the book that has been edited by you. The reason I say this is that it's saying a lot of things, but it is at the same time not really able to address some of what I think are the important causes, both within the health service system as well as outside it. One of the things that's missing as compared to the Alma Ata Declaration is the politics, the larger global as well as the national politics. And to sort of address it to what Ritu was saying, why is it that India in a period of high sustained economic growth is not investing more in health? And even when it chooses to invest in health, why does it choose certain kinds of initiatives that actually expand commercial interest? I mean, I think that is really the difficult question which has not been addressed. So we say a lot of things that are important, that are of concern, that we all agree should be things that the health system should do, but we are not really taking on the difficult causes.
Well, I have to declare my conflict of interest because I was part of the Secretariat that supported the Commission. So conflict or actually interest, and there's a couple of others in the room. I think the issue that the report is somehow decontextualized from the political environment is one that Emmanuel Bryn made, I think, rather persuasively. But if you look at the three overarching recommendations dealing with improving daily living conditions, really they use the word tackle the inequitable distribution of power, money, and resources, and that's pretty strong language. You can't, it's not shy. I wouldn't say that they're being shy there. And then the third being improving, continuing to monitor and measure the issues. I think there's a research agenda, there's a national strategies for trying to improve data collection. I mean, as reports go, it throws out an agenda, and then it's up to a wider range of people to grab on or latch on to that agenda and use it. I think there's sufficient material in the report and in the recommendations to run with it, but that political support and that bottom-up social support can't come out of a book.
Please, could you just... Yes, if you could, or you can speak into this if you want.
No,
yeah.
Okay. My name is Avni Amin and I'm with the Reproductive Health Research Department. I just wanted to thank both Rama and Ritu for an excellent presentation. I had, the observation that I picked up from both your presentations was obviously, we've talked about the role of socioeconomic inequalities as determinants of health, but obviously the presentation that Rama, you presented, talks about the role of the health sector in worsening those social inequalities. And Ritu, in the last sort of 2 slides, you came to the point where my question was mulling in my head, which is in the World Health Report, the sort of norm that's been set that it shouldn't really be more than 15 to 20% out-of-pocket expenditure. And sort of taking that a step further, my question is, what is it within the universal, the 2010 report, and if there has been any policy type of recommendations within the work WHO has been doing to really tackle the role of the health sector, the health system's financing policies in not worsening those inequalities. Because yes, there's a lot that the inequalities that have to be addressed outside the health sector, but surely we also have a huge role in setting those financing policies to make sure that those inequalities are not worsened for those populations. So I guess my question is, do we have recommendations related to that?
Well, I'm not the best person to answer that. I'd prefer David Evans to do that. But what I can say is in the report, there's a framework. And I think the 3 questions that I put up in terms of, who's covered, what interventions are actually covered, and how is it paid for. Analyses at a national level to actually look at those issues by different population groups, whether it's geographic or by different social economic characteristics, that would be the foundation to support a policy decision to move forward. The analysis is not going to make the policy decision. And certainly I think what the department, and I think as an organization, there is I believe a fairly high priority on the issue of universal coverage. There is a World Health Assembly resolution draft that was passed by the Executive Board in January and will be discussed in the next 2 weeks specifically on this issue. So I think the stars are lining up once again, and how far we go, I think, will depend on member states and working together. But the technical basis to move forward is there, and I think it's terrific that the organization has now once again reaffirmed what Tanahashi outlined in a bulletin paper back in '78, what directions to go, but it needs a significant push.
I just want to unbundle universal coverage as well. The more recent debates in India, you find several strands to this universal coverage, the idea of universal coverage. You have one which is a statist view, where you say that the state needs to really play a much more strong role in planning and regulation, and therefore, increase investments and that bit of the story. There is also another point of view within the Indian government, which tends to argue that you just tackle financing. That is, you increase public financing in the form of some forms of social insurance. We already have the targeted insurance scheme covering the poor called the Rashtra Swasthya Bima Yojana. So there is that one point. So you only work with the really marginalized. You try to increase demand. So you're doing demand side kind of financing. But the provisioning could be the state or the private sector. Now, the Janani Suraksha Yojana is a classic example of that. So you have, it really falls into this conditional cash transfers kind of argument for universal coverage. Now, the third is really looking at how, in the Indian context, you allow the private sector also to get involved, and so you have several partnerships for universal coverage. So in my view, all these are different ways in which universal coverage can be achieved. And in fact, the Obama model of universal coverage is very subtly lurking in the background. And, and I think we need to unpackage this idea of universal coverage and look at what are the different kinds of ideologies that seem to be defining what is universal coverage. Because you and I may say we want universal coverage, but the way in which we actually design health systems may be very, very different. And here again, I come back to the question of what is the role of the market and state. If you are building in public insurance, are you incentivizing markets more? And the data from the NFHS3 seems to show that the JSY deliveries are much more in the private sector than they are in the public. So I think we need to really relook at some of these evidences. No, I completely agree with the comment that has been made, because if you look at commercialization, you've really focused on the curative aspect. And this really comes from a historical context of dividing the preventive and the curative, in a sense, into a public and merit goal kind of an argument. And in fact, many of the initiatives that have been put in place through the financing side have really pushed for a medical model, and I really think that it takes away from any ideas of intersectoral linkages in the, for health systems, and the health systems are in a sense weakened by these, and they don't really have a, in terms of power distribution for policy, health systems are getting weakened in health ministries as compared to the finance or the trade or the other ministries that seem to have much more power.
I mean, going to public-private partnerships, I mean, this is something that most governments are now promoting, WHO is promoting in various fields. And from, specifically more to Professor Baru, your talk, it seems that the interaction of the private sector with the health sector for, richer and more educated people is actually quite good, because it gives them more choice, probably more efficiencies. But for the poorest and most marginalized, it seems that actually that interaction is detrimental to their health. And I just wondered if you want to comment a bit more on that. If I understood your talk anyway, correctly.
Thank you. Yes, the public-private partnerships, in fact, the National Rural Health Mission has a component of public-private partnership to increase and improve access. And interestingly, I was the co-chair for that task force group on PPPs. And what I can tell you is that there was this continuous debate and dilemma within the group about PPPs at the primary level of care. Because who are the private at primary level care? I mean, you can have NGOs, yes. I mean, and there was that partnership that was possible. But if you looked at the for-profit providers, they were informal practitioners. So were you going to legitimize partnerships with the informal sector where you knew the quality of care was poor, and you knew that, and in fact this study I quote of Jeffries in rural Uttar Pradesh shows you the extent of irrational use of medicines in delivery, especially the injecting of oxytocin to speed up labor. So you have the irrational and dangerous use, but which is really promoted by the informal sector. I'm not saying only the informal sector does it, because then cesareans is at the other end of the formal sector. So I think this area of public-private partnerships there's been mixed evidence. There have been some partnerships that seem to have worked, but nobody has assessed these PPPs from the lens of, one, equity, and two, whether these are really partnerships. In the Indian context, they're really contracting out of services. The government just says that, okay, let me just contract this out, let me get this headache out of my way, let the private contractor run my facilities. So how effective is it, or how efficient is it for health systems, is something that has not been adequately questioned. Have I answered your question, Rama?
We have another point from Francois Barten through the webinar system. Forced displacement in many countries is contributing to increase of women without clear identity. This influences sexual and reproductive health. Women's organizations are making a difference. Can you comment, please? Rama, Ritu?
I don't know which, I mean, if he had sort of been a bit more specific about the region, it would have been useful. But I know from the literature on conflict in health that this has become a major issue, not just for reproductive health, but also for infectious diseases and access to services. So the literature really is coming largely from Africa and parts of Southeast Asia, where there have been prolonged conflicts. And the most marginalized in these cases are really people without identity, I mean women, men, children, and therefore their access to services becomes a very, very problematic. I mean, they just don't have an identity, so they don't get access, and many health programs require you to have an identity to get treatment, tuberculosis being one case in point. And I really think that therefore it would influence sexual and reproductive health as well. And I don't know to what extent, and here again you need the historical and regional specificities to talk about women's organizations making a difference. I think there is much variation in the forms, nature, and the ideological predilections of women's organizations themselves. So I'm not too sure, I can't really comment on the women's organizations making a difference.
There's one more question. Why don't you start asking, please, sir.
Thanks for the wonderful presentation. My name is Siddhi. My question is to Rama actually. You make a case, you make an argument that commercialization in health has increased the gap. Now, commercialization is nothing new in India. It's happened in other sectors, education for example. And it's got a mixed picture there. You have beneficial effects for commercialization, for privatization of education in the primary, but not so much as in the higher education. So what are the lessons that one can learn from the education sector that one can apply in the health?
Difficult question. I've been looking at school health services, and therefore have been looking at schools. And I think what has happened in both the education and health sector is a certain, there is a certain divide now of public for the poor and for those who can pay the private. I mean, these are the parallels you find both in health and education. And both in health and education you have variable quality. They both, in a sense, mimic the social hierarchy, and therefore you have institutions that are on the one hand, so-called private English schools, like you have small private clinics that may be run by people who are professionally trained, who may not be professionally trained, and you have the entire spectrum. So it's very difficult to actually judge quality in terms of public versus private. What has happened with the exit of the middle class from public provisioning, and that's another big story, I think, in many of our countries, where there has been weak solidarity. Whereas in many of the European countries, where there has been a stronger solidarity and a commitment to, say, health services, you haven't found the exit of the middle class. The moment the middle class exits from public systems, you see a collapse of quality in public systems. Because there's a very famous book by Hirschman called Exit, Voice and Loyalty, and I find that book a fascinating book when you look at education, health, many of the social services. His point was that when consumers are unhappy with a service, they have three choices. I mean, there are two choices. One, to exit it. And in many of our countries, there is an exiting of from public services and moving into a private sector, which is very variable. The other is to have a voice. That is, you actually protest and say that we want better quality. That can be articulated politically, it can be articulated through civil society organizations, social movements. There can be very many forms in which you can have a voice that's given. And in fact, I remember the early writings on Kerala used to be that there was a very strong voice. So if a PHC doctor did not appear in a primary health center, there would be a crowd in front of it, and there would be a demand that he, is available when he's supposed to be. So there were examples of voice in that sense. And he says that if you will only be able to sustain institutions if there is some loyalty that's built in. And in a sense, the argument that I was trying to build is commercialization has kind of eroded all these three possibilities. I know we write about it in terms of accountability. To me, the exit voice story comes there. But the loyalty of even the people who work within the public health services has eroded, because the constant comparison is, and this is true of education as well, the constant comparison is the batchmate of mine who passed out with me, who now practices in corporate hospital in Delhi, earns maybe 20-25 times what I earn, and he does probably less workload than I do. And in a sense, there is a resentment and an apathy that gets built in. And I think this is really at the sub-structural kind of, or deep structural level of what's happening to morale of public personnel. And schemes like incentivizing, which was also done in education, in a sense also leads to commercialization. That is, if you pay me for what I have to do, then I'll do it better than what I'm supposed to do for the salary I earn. And this incentivizing has come to stay. And the third, which happened in education, which I think may have parallels in health, is the idea of a para-teacher. Because you can't afford to pay, or you wish not to pay for services, because these are all labor-intensive and ultimately labor-dependent, sectors. So you don't pay, and you have what you call as para-teachers, who are less trained, but who will do the same work for you, and will do it where others won't go. I mean, your skilled personnel won't go. Is seen in a sense partly by the ASHA kind of idea, but I would see that sort of catching up and being a kind of a substitute for not hiring people, because one of the spin-offs of the health economics debate of the 90s is you have to cut down on labor costs. It's eating up 80% of your health budget. So how are you going to rationalize costs? And one of them was to cut back, contract out, have contract employees. So you find a lot of those parallels between education and health. The only major difference is health is about life and death. Education is not. So when you talk about choices that people make, the demonstrative effect of the middle class, the demonstrative effect of high-end private sector has a very important role in shaping behaviors and why people go into debt and the choices they make.
Running out of time, and the library may want to use this room for something else. We'll end with a couple of questions through the webinar system. This is from Professor Sujata Mukherjee in India. What is the percentage proportion of female population served by institutionalized care in India? Isn't it true to argue that majority of Indian women are provided for by informal caregivers? If so, how does commercialization affect them? Also, is there any way to determine the proportion of female population in India affected adversely by commercialization of maternal care? And then, yeah, so do you want to...
Well, on the skilled birth attendants, in terms of having a skilled birth attendant, the latest figures for India as a country, which is available on the MDG website, is 46.6%.
I would in fact say, the data I have presented in my slides show you the proportion of deliveries in the health facilities. But I think I would really argue that even informal providers is a form of commercialization. I don't see why we keep them out of the ambit of commercialization, especially when they charge for services. They're using many of the practices that so-called high-end private sector does. So therefore the informal provider is also a commercialized health services.
The last question for the day is from Dinesh Newpane. How can we cope with increasing privatization and commercialization in the social sector, including health, education and social services? Could you comment on this based on South Asian perspective? A general question, but perhaps a good way to end.
I think that there is hope in South Asia because there are some countries that have been able to work together and put in policies. It's not only Sri Lanka and Thailand, and they're complex societies, but they seem to be able to move forward on working together towards greater coverage and more standard services and care for a broader proportion of the population.
Now, I'd like to also go with what Ritu said, and I think that it is really about the politics of do we see equity and social justice as important. But I think in the context of India, you have a lot of variation in the way in which health services function, but commercialization is a common theme across. And I really don't think we can now run away from commercialization. In fact, sometimes I worry when people say that we need to increase public spending, but increase public spending for what and how? And I think somewhere we need to have an audit of looking at some of these newer initiatives. Is it really leading to greater commercialization of the health services? Or, education is also another sector, or is it that we need to bring in the role of the private sector into health planning and not keep it as a separate entity outside it? Those are really the challenges for South Asia.
Thank you very much, and I'd like to thank the speakers for their wonderful, thought-provoking presentations. We have another seminar on childhood immunization on the 15th of June, so we look forward to seeing as many of you as possible then. Thank you very much.